think we're ready to go. Good afternoon, everyone. Welcome to people in the room. It's a pleasure to actually have people in person and online, very much a hybrid meeting. I'm Dion Stub, and together with Associate Professor Jeff Lefkovits, it's my great pleasure to welcome you all to the launch of the National Cardiac Registry's 2023 Annual Status Report. I would like to appropriately begin with an acknowledgement to country and acknowledge the traditional owners of the land upon which we stand today, the Wurundjeri people of the Kulin Nation. We acknowledge their connections to land, sea and community and pay our respects to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islanders people here today. The National Cardiac Registry is a Commonwealth-funded clinical quality registry with a vision to harness insights from national cardiac data to drive better outcomes for all Australians. The NCR is gratefully supported by funding from the Australian Government, the Department of Health and Aged Care under the National Clinical Quality Registry Program. The NCR successfully collaborates with all state and territory-based cardiac registries with support from cardiac specialists, local health services, governments and health agencies. This afternoon, we are presenting the clinical findings from the NCR Registry 2023 Annual Status Report. This report is a wonderful example of the foundations laid and the momentum gathered for the registry to deliver on its intent and objective to highlight clinical outcomes, importantly identify variations in care and opportunities for excellence in the quality of cardiac healthcare across Australia, beginning with coronary intervention procedures. The whole NCR team is absolutely delighted to be joined by lived experience consumers, medical colleagues, private and public hospitals, clinicians, including interventional cardiologists, endocrinologists, geriatricians, general physicians, and cardiac nurses. We are importantly also joined by health services data managers, state and territory government departments and health services, the TGA, the Commission on Safety and Quality in Healthcare, and the Australian Government Department of Health and Aged Care. We have researchers, peak bodies such as Her Heart, device manufacturers, other companies from within the cardiac space, and private health funds. It's truly a collaborative environment. And this afternoon, we will hear from key stakeholders and state-based registry partners in Queensland, South Australia, and Victoria. To get us started, it is my great pleasure to invite Dr. James Leitch to provide us with an important message, and James is the chair of the NCR board.
Really sorry, but some technical difficulties at the moment, so James isn't able to join us. So.
Okay, we're going to bypass James.
Sorry, thank you.
Okay, we'll come back to James. So then beginning is Professor Susannah Ahern, and she, it's my great pleasure to introduce you. Many of the people online and the room will know her. She's a wonderful contributor to the NCR. She's Divisional Co-Director of Clinical and Health Data Outcomes, Innovation and Research at Monash University, as well as Principal Investigator for 6 clinical quality registries. Professor Ahern will give us an introduction to the NCR, and we thank her for a wonderful ongoing contribution.
Thanks very much, Dion. And thank you to the NCR team for inviting me to say a few words at today's launch of the 2023 National Cardiac Registry Annual Report. And I'd like to join Dion in welcoming everyone at today's launch and to thank you for your interest and commitment to cardiac care. I'll just be providing a brief introduction to the NCR at today's launch. So as has been mentioned, the NCR is a national registry, so it brings together and consolidates information regarding the clinical care and outcomes that Australians receive when they undergo cardiac procedures, importantly, whether this is in central Melbourne or in regional Queensland. Like all CQRs, the NCR is patient-centred and clinician-led. It is funded by the Commonwealth Department of Health, has active engagement from the states and territories, and is increasing its uptake from the private sector. The information that the NCR collects and analyses is primarily used by health services and governments to evaluate the quality of care they provide and whether there are opportunities for improvement that may lead to better outcomes. CQR data can also be used by health services, governments, and their agencies for service planning, to inform health policy, and to monitor device safety. CQR data is an asset that can be used by researchers to provide unique and specific insights into factors that are associated with excellent as well as poorer care and outcomes. The vision of the NCR is the same as for all CQRs, to use data to improve patient outcomes, as the National Joint Replacement Registry has done for over 20 years, as the Stroke Registry has done for 15 years, and as many other CQRs aim to do. The critical success factors for CQRs to achieve this are: 1, that they are clinician-led and have the support of the relevant clinical societies; 2, that they have consistent funding; and 3, that they are managed by an organisation with expertise in CQRs. The NCR ticks all these boxes. One of the ways in which CQRs use data to drive improvements is by benchmarking outcomes across different processes of care and outcomes of care. The NCR is committed to identifying excellence in performance and outcomes and in learning from this, as well as in guiding and assisting those settings where outcomes may be less consistent. By collecting the same clinical data at the same time points for all patients in the NCR, it can provide meaningful information to support service and clinical decision-making. So how can this vision be achieved? It involves a lot of work and it takes time. Essentially, the NCR needs to engage with and assist every eligible hospital across Australia to participate, whether that's individually or via a state-based registry. And the NCR is not mandatory, so clinicians and hospitals need to commit to undertaking this activity in addition to their clinical service and other duties. However, there are many benefits to participation, including receiving benchmark reports and the use of data for clinical audit and local research and improvement activities. Another benefit is that a national registry will produce outcomes that can be compared internationally to provide a clearer understanding of how we perform compared to international best practice. Further, CQRs, including the NCR, encourage secondary use of the data for research purposes to utilise its high-quality clinical information to draw insights that are credible and meaningful to Australian clinicians and cardiac researchers. One of the barriers to participation in CQRs is the reliance on manual data collection currently. The recently released Australian Digital Health Agency Strategic Plan and Roadmap highlighted digital system interoperability as a key enabler in reducing duplication in data collection. There are many challenges associated with creating greater digital interoperability. However, over time, this will lead CQRs to becoming more integrated with the broader health data infrastructure and therefore will become a more accessible resource for wider use. Another barrier to participation in CQRs are the numerous and varied approaches to data governance, both by hospitals, jurisdictions, and registries themselves, and their approvals. There are examples where trust-based data sharing arrangements are being established, such as via the Commonwealth's Data Availability and Transparency Act, or via sharing of hospital data with associated universities. And these sort of initiatives will also support reduced data duplication and more ready access to the different sources of health data for a broad range of purposes. So what will success look like for the NCR? Like all CQRs that are in their early years, the primary focus for the NCR currently is on engagement and participation. For NCR data to be meaningful, it needs to be representative of a large proportion of the population and it needs to be accurate. Secondly, NCR reports need to be reviewed. So for hospitals to consider how and if the information provided can be actioned to inform or improve practice. A national registry provides the opportunity to learn from others, whether it be from hospitals in the same region or a different state or internationally. So the NCR provides the basis of a learning health system and offers a unique and significant opportunity for ongoing continuous improvement in cardiac procedural care in Australia. Thank you.
Thank you, Susannah. That was fabulous. I think we're going to toggle back to James, who is a grateful chair of the NCR board, and we have a message from him who is online. Thanks, Jim.
Second.
Just bear with us, guys. Just want to make sure he's
Just promoting Jim to panel.
cool. Thank you. So everyone, we're just trying to make sure that we can get Jim online. Seems like he's having some technical difficulties. Do you mind if we move forward and we'll come back to Jim shortly after, hopefully? So back to you, Dion.
We're going to get to Jim eventually. A great privilege to welcome Associate Professor Jeff Lefkovits to the stage next. He's chair of the National Cardiac Registry Steering Committee and director of the Royal Melbourne Hospital's Cardiac Cath Lab. He is a wonderful interventional cardiologist with over 25 years of experience, has a decorated career in both clinical and research, and is a great collaborator and friend. So, Jeff, very pleased to hear about the clinical findings from the 2023 annual report.
Thanks, Dion. And I have to say it's with some pride to stand here this afternoon on behalf of the Steering Committee and the National Cardiac Registry to be able to present the data or clinical findings from the 2023 Annual Status Report. And I thought to contextualise this presentation, it's worth posing this question in the beginning of what can a National Cardiac Registry, Clinical Quality Registry actually hope to achieve? And so I'll try and frame my answer to this question in examples of how the NCR is working. And before we go into details about the clinical findings, it's always worth keeping in mind what the current Australian landscape is with regard to cardiac registries in general. And there are quite a number already existing. Some are state-based and some are national. And there are several areas of interest. Some are with cardiac conditions like adult congenital heart disease. Some are with cardiac procedures like ANSCATS, the cardiac surgery database. There are some with cardiac devices like TAVI with the ACOR. And all these various registries have different funding sources, some from research, some from government, some even have user pay models. And there's limited interactivity. I think it's fair to say there's not that much cross-fertilisation among the various investigator groups. They kind of work separately on their own. And as a result, there's a wide spectrum in registry structure and function. For example, with the way that risk adjustment is done, governance is undertaken, management of outliers, and even public reporting. So if we take an international perspective for a second, and these are data from Luke Dawson, who was one of our PhD fellows over the last few years, and he did this very interesting study where he was able to find 155 cardiac registries, national cardiac registries in 49 countries. And he tried to assess the quality of these actual registries. And to do that, he used a validated registry grading score. And he came up with this sort of heat map picture here that we can see. And basically, the lighter the colour, the lower the quality score for that country. And the darker the colour, the better quality score for that country. And we can see here, with regard to Australia, that we're kind of in the middle. We're kind of middle colour. We're not that good, we're not that bad. We're kind of the middle. And sort of gallingly, if we have a look at our closest neighbour there on the right, that New Zealand is darker. New Zealand had a better score than Australia. so that we can see that in terms of where we are at the moment on a global perspective, we've definitely got a presence, but there's certainly room for improvement. And Luke was able to determine, this sort of fits in what Susannah was just saying, that higher scores, registries that are seen to be successful, have a number of common features. One of them being that they're government funded. Secondly, they have mandated enrolment, their use of risk adjustment, and linkage to other registries. So the NCR has a number of those characteristics, not all of them, and therefore there is definitely room for us as a registry to improve as we go forward. So now focusing more on a national approach, and I'll go back to that question of what can national cardiac registries hope to achieve? Well, the answer is here on this slide. I've highlighted 4 particular points. Firstly, with a national registry, there can be standardization of quality metrics. So if we look across the country, all the various registries involved, so if there was some sort of standardization, it promotes consistency, and in particular, it supports those states and territories who are at earlier stages of registry development. Tracking and analysis of cardiac procedures and devices is a clearly important role for a national registry. It provides a centralized data set. We can look at demographic trends, geographic and subgroup differences, and in particular focus on unwanted variation in care. But there's also other roles, and one of them is the monitoring and the compliance with national care standards. So one of the ones that we see quite a lot in the PCI area is the ACS care standard, which is put out by the Safety and Quality Commission. And then we can measure our performance in terms of ACS management and helps assist states and territories in their public health policies. And fourth, there's obviously an important role with research opportunities. So the NCR was established in 2019, and we chose a federated model, which means that each individual state and territory was initially responsible for the collection, the analysis, and then the submission of their data to a national centralized data set. At first, it focused on the public sector, but we now include private hospitals. And it's fair to say that different states and territories are at different stages of development. So that's one of the issues and challenges that we're facing at the moment. And there's a pool of 50 to 60,000 angioplasties performed in Australia each year. So our ultimate aim is to capture every single one of those PCIs in our registry. So where are we up to at the moment? So in the end of 2022, which is the data that the 2023 annual report reflects, there are currently 57 hospitals contributing data, with over 72,000 cumulative procedures recorded in over 3 years. And our target obviously is to recruit all PCI performing hospitals by 2027. And if you have a look there at the graphic on the right of the slide, that we see that we're approximately 50, we've got 50% of hospitals in Australia that are currently contributing. Another quarter are in early stages of participation, and there's still another quarter approximately that we're trying to enroll and recruit. So going back to those points that I made earlier and how they apply to the National Cardiac Registry, firstly, with regard to standardization of quality metrics, the steering committee and the various state and territory-based registries that were involved in the setup of NCR came up with these quality metrics. There are 11 performance or outcome and performance measures that we use. These are typical for angioplasty. There's nothing sort of too unusual with these ones. You look at obviously things like in-hospital mortality. We look at bleeding rates. We look at rates of unplanned cardiac readmission. And we can see there on the columns on the right, we can see the data completeness. So some of these quality metrics, virtually all hospitals and all registries are reporting, some not so many. And this is kind of the challenges that we face, the data completeness. When we look at the sites contributing, large numbers of hospitals, well, not every hospital provides all the data. And similarly with the states and territories, most states and territories have all this data, but some states and territories don't have all the data. And this is one of our ongoing challenges in order to get this sort of universal coverage across the whole registry. If you look now at the tracking and analysis of cardiac procedures, and again, with some pride, I put up this slide here because it's the first time I think that we've put a slide like this in public, looking at the Aboriginal and Torres Strait Islander demographics, the distribution of PCI patients by age and sex. And in this group of 2022, there were 633. So it's an incomplete data set. We think there were more people, First Nations people who have PCI than that, but these are the ones we've got in our registry. And what we can see from this particular graphic, which I haven't shown the contrast here because in the interest of time, but this looks different to the non-Indigenous population. And firstly, if you look at the sex distribution, if you look at both sides, male and female, they're approximately, not exactly, but approximately equal. Whereas if you look at the non-Indigenous population, you get a preponderance of males, like 2 to 1. So we can already see that the Indigenous population has a different demographic in terms of sex distribution. And similarly with age distribution, this is weighted much earlier, much younger. If you look at the less than 50, we're getting 20% and 12% of patients are made up of people who are under the age of 50. Whereas if you look at the non-Indigenous group, we see that graph higher up. It focuses on the 60s, 70s, and 80s. So we can see now that with these data, we can already start to map out that there are areas of focus and where health planners and should be focused on when trying to work out appropriate care for the various diverse groups that we look at across Australia. Another example of how tracking and analysis of our data can be seen in this slide with regard to the utilisation of hospital resources. So this slide here looks at number of, or the proportion of cases done in hours and out hours across the country for the various different clinical presentations. We have non-ACS, so those are people who are elective or non-emergency type cases, and they're predominantly done during hours. And if you go down there and look at non-ST elevation acute coronary syndrome cases, or the time-critical STEMI management, we can start to see that hospitals will start to need more and more resources to cope with the out-of-hours work, such that hospital health providers and hospital planners will see that if they've got a large proportion of the cases that are STEMI, that they're going to need to have better resource utilisation in terms of after-hour cover. And as a third example, regarding tracking and analysis, I put this slide up with regard to the use of the radial artery for access for PCIs. And there's definitely been this move towards using the radial artery rather than the femoral artery over the last 10 or years, so right across the globe. And NCR has been able to track this even over the time that it's been involved for it, so we can see a national approach, and it's been increasing even over the last 3 or 4 years. It's still growing. We're now getting close to 80% of all PCIs done via the radial approach, with some hospitals ranging from 50 to 95%. We see a slight difference between public and private, but that gap is closing. There's no reason why there should be a gap. The same operators are in the two sectors. And similarly, the gap that was between males and females being more common in males, that gap also is closing up. Perhaps there may have been hesitation in the past with the females because they often have smaller radial arteries and a bit harder to get into, but over time we're all used to that now, and hopefully we'll see that gender or sex makes no difference in terms of radial access usage. So moving now towards the idea of using the data to help monitor and compliance with national care standards. And for the NCR, probably the best example of that is put up here on this slide when we look at the acute management of patients who present with STEMI. Because it's time critical, we look at the various time intervals to make sure that there's no undue delays. And so we can see here the journey from the time of symptom onset to the time of reperfusion. If you look at the first time interval there, from symptom onset into FMC, which stands for first medical contact, and that really is outside the medical system's control. It's when a patient comes and says, you know what, I've got symptoms, I think it's time for me to go and seek help. And that really is, that's 58 minutes, so it's a bit under an hour, which is pretty good. With some of our studies, and we've seen that blow out much longer. And that really is where public health initiatives are important. Campaigns like the National Heart Foundation and others help with patients' health literacy to help them learn that they should present early if they have a suspected heart attack. The first medical contact to diagnostic ECG, the median time is 8 minutes, and that's impressive. That's well within guidelines. Guidelines are 10 minutes or less. So Australia is doing very well in that regard. And then the time from diagnostic ECG, which is basically the time that you say, yes, this patient has a STEMI, to the time they get to the hospital, a median time was 43 minutes. Again, it's a bit out of control because it depends where the patient is, where the nearest hospital is, and so on. So that's not quite, it might be sort of pre-hospital issues like ambulance and so on have more of an influence in that time interval. But where hospitals in particular have a lot of control is from this point on, from arrival at PCI hospital to the time of reperfusion. And so the median time here in our data set was 56 minutes, which is below the guideline of less than 90 minutes or preferably below 60 minutes. So that looks good when we look at like that. But when we look at it more closely, and we look at it here in this slide, for example, we were comparing door-to-balloon times, that's time from arrival hospital to the time of reperfusion across the last few years. We see firstly, initially, this good result, but we're always above the 75% sort of target there in terms of 90-minute targets. And the dark purple there is, all of them are above the 50% target range. So that looks good. But what we can see is that there's no change over time. We're not improving. We're kind of static where we are, particularly with the, getting the door-to-balloon time done within 60 minutes. And moreover, if we look at what these data actually represent or reflect, that we're looking at, to get those results, only 20 out of the 40 hospitals were able to get their door-to-balloon times with less than 90 minutes in 75% of all cases. So there's still another 20 hospitals that could do it if we could get them there. And if we look at the best performance, which is trying to get your door-to-balloon time less than 60 minutes, only 3 out of the 40 hospitals actually got it done within 75% of their cases. So there's definitely room for improvement. And if you don't look at this, if you don't measure this, you'll never know this. And so we can look at a number, we get a median of 56 minutes, we think we're pretty good. But when we look deeply, more deeply than that, we can see that there's a story to tell. So how do we do that? How do we get hospitals to improve their door-to-balloon times? One of the ways they can do that is by pre-hospital notification, PHN. That means that when the patient arrives at their first medical contact, that first medical contact, usually the ambulance, will then contact the receiving hospital that the patient is coming, so that hospital can get ready for them, and so that the delay from hospital arrival to PCI is minimized. So approximately 70% of our cases already came to the hospital with pre-hospital notification. All hospitals that do PCI, primary PCI now, will have a program already developed. So it's not like it's not developed. So what is that 30% gap? Well, that from 70 to 100%, mostly it's patients who self-present. So these are patients who come to the hospital, they think they've got chest pain, they're not sure, they don't call the ambulance, they come there, and guess what? They've got a STEMI, and then the hospital has to say, oh, there's a STEMI, and then the whole wheels have to start turning. So again, this goes back to patient education, improving their health literacy, public health programs into educating patients to present early to suspected heart attack. And if they do that, they can reduce their door-to-balloon time from around 91 minutes for non-PHN cases to down to just 47 minutes, which is fantastic, with pre-hospital notification. So the last data slide I want to show here is just an example of the type of data that we are also producing, which is our famous funnel plot. The funnel plots look at performance outcomes, benchmarking hospitals against themselves, and by statistically analysing, see whether they're above or below, certain degree above or below the mean. And this is an example here of just one I've just plucked, 30-day unplanned cardiac readmission rates. And the reason why I've chosen this is to show you that there were a few hospitals here that in our early analysis looks like they are more than 3 standard deviations away from the mean in terms of their performance. So this is the type of data that we were going to look at in the future. At the moment now, it's too early to make strong inferences about those hospitals' performance because we only have incomplete data sets, so that the statistical analysis is not necessarily robust enough to say hospitals A, B, and C have performances that are outside the 3 standard deviations. But they will, as we grow, as we include more hospitals, as we get a more complete data set, these funnel plots will become critical for our data analysis and publication. So what's our 5-year strategic plan and roadmap? The first is that we need to increase site engagement and recruitment. That's through the member registries and also through what we call a direct data entry model, where there now is facility for hospitals in states that have early stages of the development of state-based registries will be able to directly enter their own data into the NCR central data set. So we'll have both systems going at the same time. We also are hoping for improvement in harmonization of data sets, so that we'll aim for a universally collected minimum data set. That first slide I showed you there about the standardization of quality metrics, we'd like to see 100%, 100%, 100% after each column. We're obviously planning on establishing new modules. We're looking at implantable electronic devices and AF ablation. Links with other national registries are key. That from Luke Dawson's work, we can see that's important for a quality registry. We can form links with the cardiac surgical database, with the valve dataset, ICU, administrative datasets, and there is really almost limitless research opportunities. I just put a few, the Australian Cardiovascular Alliance. We can do registry trials, we get international collaborations. The opportunities are almost limitless. So in conclusion and finishing, I'd like to have a few acknowledgements. I'd like to certainly acknowledge the support and the vision and the encouragement of the Australian Government Department of Health and Aged Care to get NCR up and running and for us to continue our good work. I'd like to thank the NCR board and board directors for their guidance and their support. Really, the steering committee members are the backbone of the registry, including the state and territory registries, and we have to acknowledge their input and their interest. And really, we have to also acknowledge the Monash management team. Without them, we would not be here today. So the NCR would not be possible without the participation of the thousands of patients and their families who have shared their data so that we can improve health outcomes across all Australian. And the last slide there, encourage people to download the annual status report, which is now online, including our little fact sheets. Thank you very much.
Thanks, Jeff. That was absolutely fabulous data presentation. We're going to do a question and answer segment at the end where we're hoping both for in-person and online questions. And so now we're going to take three. And that Dr. Jim Leitch, Chair of the NCR Board, has an online message for us.
And hi all, I hope you're able to hear me on this occasion. Is that correct? You can hear me?
Yeah, I can hear you, Jim.
Right, good, excellent. Look, sorry about the technical issues. I just had something very brief to say that it's a really wonderful report. It's a fantastic achievement by the whole NCR team. You've just heard the thanks from Jeff. I'd also like to thank all of the states and the territories for their work in getting the data in and supporting the NCR, and also the Commonwealth, which funds the NCR and which has allowed it to grow and develop to what it is today. I've only been in this role for a very short period, and I'd also like to thank publicly Leo Ma. He was the initial chair. He was the person who got the whole thing rolling. He put an incredible amount of work in, and it's thanks to him it's where it is today. As you'll see from the report, the NCR is allowing us to assess the impact of PCI, both elective and emergency, on the Australian cardiovascular health, both at a local and at a national level. The details you've heard from Jeff and the other speakers. I'm not going to discuss those further, but I would like to mention that we do plan to broaden the scope of the NCR to include pacemakers and defibrillators. And I hope we'll be able to share that with you at this same opportunity next year. And I'd also like to say that the Indigenous Committee has been active, and they may also have some ideas about how we can broaden the scope of the NCR. And that's it from me. Once again, thanks everyone for the report and the work that's gone into it. Thank you.
Thank you very much, James. Our next speaker is William Vollbon, who's been working as the manager of the Queensland Cardiac Outcomes Registry since 2017, and it's wonderful to have our interstate partners online. Clinically, William has extensive experience working as a cardiac scientist and sonographer at the Prince Alexander Hospital in Brisbane, alongside work in public and private practice. He has special interests in clinical quality and safety and the use of clinical informatics to improve clinical process and outcomes, echocardiography and other non-invasive cardiac testing. William is here to present the Queensland Cardiac Outcomes Registry in talking about enabling better patient care by clinical quality registries, insights from QCOR and the NCR. Thank you very much, Will.
Good afternoon, everyone. Hope you can hear me.
I think we can hear you, Will. Yes.
Okay, fantastic.
Cool.
Excellent. So thank you very much for the introduction. I'll just move on to the next slide if we can, please, and move straight into it. So just briefly, QCOR is a clinician-led program that provides access to quality clinical and procedure data, which enables us to enhance enhance patient care and inform us around patient care and support the drive for continual improvement of quality and safety initiatives across cardiac and cardiothoracic surgical services in Queensland. So QCOR doesn't just collect data in the PCI space. We collect data over 9 clinical domains in cardiology and cardiothoracic surgery. And we provide quality and safety reporting as well as activity reporting across those specialty areas. Usually, and where able, data is collected at point of care, and the tools that we provide here in Queensland for collecting that data are embedded in clinical workflow. So we're able to collect that data once and use it many times, as is the mantra of most clinical registries, which is a real advantage here in Queensland. QCOR has also been able to demonstrate a wealth of value across multiple domains in a lot of other cost-saving activities, which we've been able to implement here in Queensland also. And I guess why harp on this? And it's because the Queensland, or QCOR, is the conduit that 8 and going on for the next year's analysis, 9 public cath labs contribute their data to the National Cardiac Registry. Next slide, please. I think we're probably all going to be pretty well harmonised today, and that wasn't by design, but in one of the particular indicators that QCOR has been looking at for quite some time is in the STEMI space, PCI for STEMI. And as we're all well aware, it's a time-sensitive treatment for these patients, and a whole of system approach to that care of those patients is required. And as Jeff pointed out, because the patient has so many touch points across many different departments or specialty areas, both pre and in hospital, there is a lot of, it makes the situation extremely complex, but it also enables a lot of opportunity for improvement across that spectrum. Next slide, please. So Queensland's results here, and this is all publicly available data, but what we've seen is over the years an improvement once sites have been able to see their own data and have this data reported back to them in a timely manner. But what has also increased is the eligibility of cases for analysis. So not only have improvements been noted in the clinical performance, but also our ability and sophistication in our analysis and the ability to get a really good picture of what's happening in the state of Queensland for those public services. But what we've also noted is, whilst we have had an improvement in performance in that median time, we've probably started to plateau. And what we also probably has to be thrown in the mix is the COVID response of the public health facilities here in Queensland, indeed across Australia. We believe that they have had some sort of effect on performance, and I don't think anyone would argue too much about that. But what is reassuring is that throughout this time, and especially over that 2022 year, Queensland's performance has been a little better than the national medians, which is positive news, and great to see here that we're able to assist in reporting that and enabling quality of improvement activities. Next slide, please. So I guess how have we been able to do that? Well, as I said, it's a multi-departmental approach. And you can see by this figure, and Jeff presented something very similar, is that there is a lot of touch points and a lot of different periods that we're able to measure with respect to the care of a patient who may be experiencing a STEMI. So fortunately in Queensland, there are sites that have great collaboration with their local ambulance service. And that's important because we can see there that the median, when we look at median times, around 60% of the component of the treatment of that patient happens pre-hospital. So engagement with local Queensland ambulance services has been imperative and has offered a lot of insight to hospital staff, and also back then to the QAS, who run, equally, they run a quality program in their cardiac outcomes registry as well here in Queensland, looking at the care and treatment of patients by the QAS. Next slide, please. So what we've been able to look at and what individual sites have been able to do is really relay back the message to the paramedics and the ambulance service staff that are on site as to the importance of that pre-hospital notification, and ensuring that paramedics are well drilled in the understanding that the overall time course or the experience of the patient is really heavily affected by the time at which the cardiologist is notified. And we're fortunate here in Queensland that there is a networked approach to that. And the notification of the cardiologist is well drilled into the paramedics' protocols and procedures. However, there is always room for improvement, given that some of these paramedics may only be tasked with 1 to 2 STEMIs per year. So understanding they've got a large workforce in the ambulance service, ensuring that the importance of this is not lost on those paramedics is an important measure and an important means of enabling quality improvement. So over the years, we have noticed an improvement in that cardiologist notified time, which I think is at the core of the reasons why those median times are improved. But as Jeff mentioned previously, the door to balloon time is also an extremely important part. Next slide, please. So future plans with respect to the NCR, Queensland Health has really doubled down on its commitment to the care of cardiac patients in Queensland by funding and setting up a project called the Cardiovascular Information System Project, which is a truly enterprise view of cardiac care for patients here in Queensland. And with this system that encompasses both the cath labs and the echo labs all across public facilities in Queensland, we're able to contribute the full NCR data set, which we're really looking forward to. Next slide, please. So in summary, the clinical quality registries such as the NCR really do enable insights and opportunities that would otherwise not be possible if they weren't available to us. Clinical quality registries constantly demonstrate a return on investment through various system-wide improvements. And the approach to quality improvement activities that take place in PCI-specific analysis is transferable to other clinical domains, meaning that once a sound platform is in place, subsequent processes and progress are more readily realised across other clinical domains. And thank you very much. I'll wrap it up there.
Excellent. Thanks, Will.
Thank you, Will. That was fantastic. Associate Professor Rosanna Tavella is a clinical data manager for CADOSA, the coronary angiogram database of South Australia. Associate Professor Tavella is a health outcomes researcher based at the Queen Elizabeth Hospital and University of Adelaide. Her research interests include evaluating health outcomes and patient-reported outcomes measures in patients with non-obstructive coronary arteries. Associate Professor Tavella will present on measuring performance in acute MI patients. Thank you very much for joining us, Rosanna.
Thanks, Dion, and thanks for the opportunity to speak at today's launch. I'll get straight into it. Next slide, please. So just a very brief introduction on the CADOSA registry in South Australia. So this is our flagship clinical quality registry program and also a research infrastructure for patients not only undergoing PCI, but also extending to those undergoing diagnostic angiography. The program has 3 key components, with the clinical data collection being the most significant one, where we have a highly detailed baseline data collection that's managed by site-based data abstractors in our cath labs. And then we work with the data linkage unit to track patient outcomes out to 12 months. However, we've also embedded a patient-related health outcomes module where we're collecting PROMs from patients during their hospitalisation and out to 12 months following discharge. And we also have a cardiovascular biobank that's integrated with the PROMs and the clinical data. But as you can see from the numbers on the slide here, that the clinical data is the main component. And when this component was initially established, our data collection elements were in line with the NCDR Cath PCI registry. But we have been involved in the NCR since its establishment, including the establishment of the initial PCI dataset, and have been contributing data for the last couple of years. In our registry, around 30% of our cases are PCI, and around 60% of our volume of work are myocardial infarcts. Next slide, please. So the NCR has really given us the first opportunity to look at national performance for acute MI care. And Jeff and Will have also already touched on this a little bit, but this is a slide from the previous annual report looking at door to balloon times for our primary PCI cases. And when we looked at this across Australia as a whole, we saw that 80% of patients were reaching that time within 90 minutes, which was very pleasing to see. And as Jeff has already said, that time was significantly reduced in this year's data report with that pre-hospital notification. But you'll notice on the slide as well that there is some variation among the contributing centres. And this is something that we've certainly observed in South Australia when we're looking at evaluating the care that we're delivering to acute MI patients. So next slide, please. So we've done a lot of work looking at adherence to evidence-based measures at discharge, so particularly around prescription of secondary prevention therapies, referral to cardiac rehab, etc. And particularly when we first looked at this in benchmarking against our international colleagues in the US, the next slide, we saw that there was significant opportunities for improvement with CADOSA. So I'll just head over to the next slide. This was our initial look at what the metrics we're looking at looks like. And certainly we saw, as I've said, opportunities for improvement. So we've done a lot of work auditing the data, working with our teams around understanding where there are gaps in practice and in documentation. And we've now moved towards very regular reporting of acute MI indicators. So next slide. So our units receive a quarterly sort of dashboard on indicators for their acute MI presentations. Next slide. And we're now seeing that these indicators are where we would expect them to be for our patient population. Next slide. So one of the things that I'll like to finish up on is where we're moving towards using the registry data and the clinical information in our registry in South Australia, and that is embedding clinical risk prediction models at the point of care. What we've recently established is a tool that allows us to calculate patient risks for for a number of adverse events for the procedure. So for our acute MI patients, for example, we are looking at their risks of major bleeding, and we're popping that into their patient risk information sheet and consent form for the procedure. One of the other measures that we've been focusing on, next slide please, is the occurrence of contrast-induced acute kidney injury, which is a somewhat common but probably underappreciated complication from the procedure. And this tool, in addition to calculating the estimate of risk for this outcome, also provides care teams with a suggested contrast limit that's been shown to reduce that risk of injury. And whilst we haven't implemented the contrast limit as a formal trial, what we have seen through analysis of the registry data is a significant difference in AKI by the contrast limit. So if I can just switch to the next slide, where we've compared procedures that have remained within the safe contrast limit to procedures that have gone over that recommended limit, we see that there's essentially a halving of the occurrence of AKI, suggesting to us that this is a really actionable insight that we can implement from this risk tool to reduce patient risk. So next slide, and I'll finish up here. So as we've seen from Jeff and from Will, registries are really powerful tools that can identify variations in practice and really improve the value that we're delivering to our acute infarct patients. But registries are also opportunities where we can work with our engaged care teams by embedding some innovative tools that may help us move towards more individualised and personalised care for patients. So I'll stop there. Thanks for your attention.
Thank you, Rosanna. Dr. Diem Dinh is a statistician and senior research fellow who has worked with the Victorian Cardiac Outcomes Registry for over 14 years. Diem will present on behalf of VCOR the potential of the National Cardiac Registry insights from a state-based registry. Thanks, Diem.
Thank you, Dion. Next slide, please. Next slide, please. VCOR is currently contributing the largest number of both public and private cases to the NCR, and is looking forward to utilising national comparative data sets in its ongoing quality assurance activities. So quickly, collection of the PCI information is VCOR's primary module, which extends to all 33 Victorian hospitals. VCOR's other current module focuses on the utilisation of cardiac and implantable electronic devices. Next slide, please. VCOR's valuable contributions to clinical research and epidemiology continue to be showcased through publications and conference presentations. The registry has formed relationships with the Centre for Victoria Data Linkage, or CVDL, at the DHHS, and with the Ambulance Victoria, providing population-wide linked data to support evidence-based research and to enhance reporting to the government, the healthcare system, and to the hospitals. Next slide, please. The next two slides showcase our recent projects using linked registry data to recommend further development and expansion of regional PCI programs to achieve high quality and equitable cardiac care for all Australians. Next slide, please. And also to unravel the full cardiac patient journey through data linkage with the Victoria Integrated Non-Admitted Health Minimum Data Set, or the VINA. Next slide, please. So central to a well-functioning CQR is the ability to provide risk-adjusted outcomes. So VCOR developed and validated its own risk-adjusted tool for 30-day mortality. However, as demographics trends evolve, risk adjustment models need reviewing. Next slide, please. So over the last 12 months, we've been very busy revising our signature key performance indicator of risk-adjusted 30-day mortality, and found that this model performs well compared to the old one, which is reassuring. Now, more importantly, when we use machine learning techniques, the ML model outperforms the traditional regression model and provides better accuracy for predicting 30-day mortality. Now, in addition, we're making great progress with our second predictive model for in-hospital major bleeding. So far, our preliminary data look promising, and we can't wait to share the results with our clinical community soon, so watch this space. Next, please. Now, in its 12th year, VCOR has established itself as a mature CQR, continuing on its cardiology improvement journey in collaboration with the Victorian Agency for Health Information. This new program aims to improve value-based healthcare delivery to cardiac patients in the cath lab, and also to improve outcomes and reduce unwanted variation by improving care processes, such as to increase same-day discharge and to reduce length of stay. Next, please. Now, in conclusion, the power that VCOR and NCR have into providing insights into cardiac care at the national level is vast, including key performance metrics, highlight variation across region and institution, risk-adjusted outcomes, focus on disparities in care, expanded breadth through data linkage, and clinical research as additional benefit to core quality activities of the registry. Thank you.
Thanks, Diem. And now we have a video from a key NCR stakeholders.
Hello, I'm here to talk about the National Cardiac Registry.
The National Cardiac Registry is a vital database dedicated to assessing, observing and sharing crucial data regarding the quality of clinical care for cardiovascular procedures and heart devices on a national scale.
The ultimate goal is to enhance both patient safety and the overall quality of cardiac healthcare.
Our vision is clear. We aim to utilise the wealth of information in the National Cardiac Registry to pave the way for improved outcomes for every Australian.
In essence, the National Cardiac Registry is at the forefront of driving positive changes and better results in cardiac care.
So what is the mission of our organisation? Our primary goal is to advance cardiac healthcare in Australia through charitable efforts.
We achieve this by meticulously assessing, monitoring, reporting on cardiac health outcomes and clinical variances.
This process helps us pinpoint areas for enhancement within cardiac healthcare across the country.
Our objectives are clear-cut.
Firstly, we oversee the National Cardiac Registry, acting as a hub for receiving data from states and territories regarding cardiac conditions, procedures, devices, and secondary prevention methods.
This enables us to gauge the performance of institutions providing cardiac healthcare.
Secondly, we believe in complete transparency. We openly share clinical, procedural, and patient healthcare outcomes arising from cardiac procedures with hospitals, clinicians, government entities, as well as community and Indigenous organisations, including Aboriginal community-controlled health organisations.
Thirdly, we ensure that our reports are not just informative, but also deeply meaningful to all Australians.
Lastly, we provide a national benchmarking service offering key quality performance measures for cardiac conditions, procedures, devices, and secondary prevention methods.
This helps us track progress and maintain high standards in cardiac healthcare.
I'd like to encourage you all to get involved with the National Cardiac Registry.
Sorry, everyone.
We're on mute. So just quickly for the online audience, Jeff, we're going to close the session. It's been fabulous summation of a real mountain of work, but just we've got time for a few quick questions. Jeff, how can the NCR improve cardiac outcomes for Indigenous Australians?
Yeah. So as I hinted in my talk, that being able to document and be able to focus on a diverse background, people's diverse cultural backgrounds is important for us. And I have to say that from the very beginning with the NCR, we identified that the First Nations peoples were really an area that we needed to deal with properly. We couldn't just gloss over it. And so what we did from the very beginning is that we set up an Indigenous Council. And they are advising us, informing us at every stage. And so they have the Indigenous Council is an integral part of the process. And we hope by that way, not just documenting deficits. That's not the idea. The idea is to identify differences, identify areas for improvement, and so that we can optimize their care and reduce variation in care right across the country for all diverse backgrounds.
So, and then we are approaching time, but the NCR has provided us with now a picture Australia-wide cardiac outcomes, and we've still clearly got room for improvement and more sites and getting a complete capture of country and PCI outcomes. But how do you think we are tracking compared to the international community?
Well, I mean, if we look at some other countries, look at United States, for example, they've got something called the NCDR. Sweden is probably really a good example for us, where it's a smaller country which has a sort of a unique countrywide health system with a unique patient identifier for everyone, and they have a suite of cardiac registries. So UK has their own registries, Canada's got their own registries, so there are and many others. So I guess if we look back to my talk, we saw what other countries around the world are doing. Australia has a presence, but we don't have a leading presence. And so this is one of the focuses of NCR, that once we can get NCR up and running and get almost complete capture of data, we will have we'll be able to hold our heads high on the global stage and be able to participate and compare and contrast and contribute to the global whole field. So we're not quite there yet, but that's definitely one of our aims.
Thank you, everyone. Thanks for everyone online. For people in the room, we have drinks and nibbles outside, very heart safe, red wine, cheese and biscuits. And yeah, thank all key stakeholders, the whole NCR team, all the state providers. It's been a fantastic session and look forward to an even bigger year ahead. Thank you very much.